Esteemed colleagues, I'd like now to give a floor to Sergei Vorobyov, whom you actually saw. The topic of his talk is capabilities of morphology methods in... Oh, no, it was yesterday's topic. Morphology studies for pathologies of extrahepatic bile ducts and ampular zone. Good day, esteemed colleagues. The second part of continuation of the talk, which we started yesterday. And my talk today will be much shorter because many of the methods which I mentioned yesterday, from the point of view of methodology, from the point of view of assessment of morphological phenomenon, they are similar when studying those organs. I mean pancreas and bile ducts. I would like to start with a general scheme of liver bile ducts or intrahepatic subliver bile ducts. It seems like the system is very simple. It's a draining system. It makes possible to move the bile through the liver duct system, and anatomically it's rather primitive versus other organs. There are not that many of tissue and structure elements. Of course, there is a quite similar epithelium. There is a basal membrane, not very intense submucous layer with vascular component, muscular fibrotic tissue, muscle wall, and adventitia elements. And the amount of pathological process, maybe tumor one, shouldn't be that much of that pathologies, but situation is quite complex for us. And to make the decision on the diagnosis of the disease, we usually should see the material, which in the ampular zone is mostly obtained through biopsies and much rare through brush biopsy. Talking about the extrahepatic bile ducts, we use lavage material. In majority of hospitals, what they can do, it's a brush biopsy or endoscopy controlled biopsy, or they use modern method, AUS FNA, which we discussed yesterday. The same schematics for method of the epithelium, which we obtained through brush biopsy. And today we discussed a lot and mentioned a lot that brush biopsy is not of a great value, especially for borderline or pathologies, pre-cancer or early cancer pathologies. It's not of great diagnostic values because it's because of the method limitations. The tricytology results, which we might expect, it's a very rare malignant tumor when cytologists could clearly state that there is a tumor, but in this situation, the tumor is an advanced tumor, which is clear for us. The processes prior to carcinoma, and coming back to the thinking about the yesterday when I answered the question of Professor Baranovsky, we said that there is a cascade, there is a special cascade of epithelial malignization with formation of advanced adenocarcinomas and intrahepatic carcinomas with relation to hepatic ducts. First of all, to those borderline processes, we relate biliary neoplasia of the third grade. Quite often, when we see when a pathological report, we state biliary neoplasia type 3 or stage 3, we imply this is not only not just simple carcinoma, but even an invasive carcinoma. The second type of precancer process is intraductal papillary carcinoma, papillary neoplasia. It has such abbreviations, that's why it has such abbreviations. A second type, it is when within papillary structures there is an involvement of tubular component, or mostly tubular component is present, as it's mostly seen in intestinal type epithelium. It's a so-called tubular neoplasia. It's another type, but they're different types because they have not only structural difference, but also they have some prognostic differences. And finally, we're talking about the fourth type of neoplasias, which are associated with mucin formation and formation of mucinous cystic neoplasia. And quite often when we find this pathology, we imply that the adenocarcinoma is present as well. And it's clear that for us to find out which type, the type of epithelium and its functional activity, for that we can use immunohistochemistry. And for differentiation of changes, intrabiliary changes, we can use a cytokeratin panel. You see different mucins to understand which type of epithelial rearrangement we have in place. If it is a precancer or cancer, assessing also the progression and prognosis of that neoplastic disease. And also it helps you to, for differential diagnosis, it's very helpful to use proliferative activity index and apoptosis impairment, because it actually indicates proliferative activity. Classification is presented in that book by WHO, and this classification is not very simple. It is based on the same principle which I mentioned yesterday, so I don't want to dwell upon that. But I'd like to mention that when we talk about adenocarcinomas of mucinous type, of the slide cell type, and glandular squamous cell and or signatrine cell carcinomas, then diagnosis for us, I mean in cytology and histology, we could diagnose them only when tumor has a clear signs of seen at additional X-rays with additional X-rays method. It's only about the type, which type of tumor we actually see. It's more complex case is when we talk about some more complex case for us. Is the tumors in the areas which primarily are located in other organs, in bile digestive zone, like in pancreas, like neuroendocrine carcinoma, with metastatic involvement of extrahepatic bile ducts, and in the major papilla area. Methods we use in our daily work, they also have been discussed. We talked about them yesterday, but I would like to draw your attention to the following. If conventional cytology is used mostly for brush biopsy purposes, then for us to use as much as possible to obtain material, of course we should take the brush and we should transport it not in formalin, but we should special transportation medium, because it will help us to take from this brush and from this medium. We can take entire material, and it will be done through the flow cytology method with centrifuging. That's a special method which makes possible not only to obtain a monolayer of cells for better, for more detailed, more accurate cytology, but also if we have a lot of that material, we can use this flow cytology to prepare the cell block which is much less in size, with less amount of material, but in any case it makes possible for us to resolve various diagnostic, to fulfill various diagnostic objectives. That's a clinical case. Patient 43 years of age, considers he's sick for 6 months. First complaint was a jaundice. After a month from the disease onset, he underwent laparoscopic cholecystomy. Clinical diagnosis was suspicious pancreatic cancer. Patient was examined in the cancer clinic 2 months after the disease onset. RHCP was done, and CT showed a strict show of CBD terminal, and else showed no signs of pancreas tumor, and CT shows no signs of tumor. Then stenting, the CBD stenting was done in 3 months. This was done, and biopsy was taken. Morphology showed that epithelium has quite clear cellular and nuclear changes, like polymer alterations, like polymorphism, chromatin alterations with nucleoli changes, and also there were some structural changes found, which being examined additionally of the cell block with CA and neuroendocrine markers, like CD56 in particular. That's the marker used for differential diagnosis of malignant and benign neoplastic tumors in the epithelium of bile ducts, with a high level of proliferative activity and low levels of P53. So these studies showed us that we're talking about biliary neoplasia 3rd grade. Talking about the differential diagnosis of dysplastic alterations and biliary neoplasia grade 3, like intestinal neoplasia, they're considered as a severe neoplasias. And in this case, we have to understand that, like pre-cancer epithelial alterations, we might have here even already developed adenocarcinoma. That's why we try not to use the term dysplasia 3rd grade, because terminologically it talks about, in a term-like sense, it talks not about the tumor. That's why we talk about the low-grade dysplasia. But when we talk about the tumor, it means, or neoplasia, it means that there is a tumor in place. And I mentioned yesterday that we're quite negative about the diagnostic method. Here they use this method to determine the resection margin, and the resection margin we found the sign of glandular proliferation with some asymmetry, with some dysplasia, which implies that in this zone with removed CBD, this area there could be a proliferation which looks to be like adenocarcinoma. The cryostate sections, but the paraffin sections shows that in this area there were no neoplastic alterations. During the surgery, they did liver biopsy, which showed cholestatic component of the small and with different level of magnification. One study in the biopsy material, we found out that there is a sclerosing cholangitis with quite considerable inflammatory and desmoplastic components around bile ducts. That's why we considered that we should study the removed gallbladder. And look here, in the wall of the gallbladder, we saw the foci, which had a similar histologic structure as those alterations which you saw in the liver, indicating that the primary sclerosing cholangitis in this case is clearly confirmed not only intrahepatically but also along bile ducts. And the biopsy of the cell blocks makes possible for you to clearly verify the ductal adenocarcinoma. When we talk the ampullar zone tumor, the situation changes because of the structure, anatomical structure of the organ, and we should understand that usually we're talking about the benign processes in this area, and adenoma could be divided into several types. It's intestinal type, pancreatobiliary type, gastropancreatobiliary type, or it could be related to so-called squamous cell interepithelial neoplasia, dysplasia, which has its specific immunophenotype, making possible to understand where the differentiation process goes on if the dysmalignization cascade is launched in a specific patient. Adenocarcinomas of ampullar area, topographically they are defined in the intraampular, preampular, duodenal, and mixed or ulcerating forms, or exophyte forms. And that's issues with differentiation of the biopsy material. Like if the tumor has an extensive growth and it's available for superficial biopsy, and a diagnostic issue is much more complex. If it is a tumor, if the tumor process is in the deeper parts of the deeper sites, and as to the histology, most of the cases we see mostly intestinal type. Second place is a pancreatobiliary type of adenocarcinoma, and the mixed one, which per se has some differences, which make possible for us to think about the disease prognosis. Neuroendocrine tumors, they also are seen in this area. They could be divided into two groups with relatively high differentiation, meaning G1, G2. But I paid attention to that. I mentioned about that because we can talk about the G1 because it has low malignization potential. The tumor of G2 neuroendocrine differentiation, they have unpredictable prognosis. They could have low proliferative activity but be very aggressive in the course of the disease, in the clinical development, and the parameters of mitotic activity, proliferative activity is from 2 to 20%. It's a very wide range, and most probably they should be studied. They should be subgrouped within the second group, or we should think about maybe some other markers more important from the point of assessment of the malignization level. Another value of this group that in majority of cases, and I think we will come to that, that the main method to treat such patients will be not the surgery but chemotherapy or targeted chemotherapy, and that's why differential diagnosis and finding and finding the details about those tumors, I think will be of a higher value. Neuroendocrine adenocarcinomas, these are very malignant from the point of view prognosis, and their cause is similar to usual adenocarcinomas. There's now a second clinical case. It's a woman, 63 years of age. She has the endoscopy showed large tumor of large papilla up to 15 millimeters, and we verified it as highly differentiated adenocarcinoma, papilla adenocarcinoma. It has such. It looked like that, and we studied CBD and pancreatic duct. And cytology showed quite clear intraoperational sign, and also intraoperational study was complicated with irregular tubular structures in submucous layer, which always makes differential diagnosis with adenocarcinoma, and it's related to the case that, first of all, that nephrologists, they know it, the differential diagnosis of highly differentiated ductal carcinomas of extrahepatic ducts is often accompanied with a very low level of cell-to-nuclear polymorphism. I mean, those signs being the basis for us to claim that it's an adenocarcinoma. That's why we often look at the type of the structure and the spread of this process. We look at the ratio of the mucus layer, submucosa, and muscle layer to say that there is an adenocarcinoma. We did histology with final diagnosis. We have a high-grade adenocarcinoma involving duodenum, and combined morphological examination, this complex makes the diagnosis more reliable. Presence of reliable clinical data is very important. We discussed it yesterday. Then adequate sample preparation of biopsy and operation material is very important. And also we should use standard forms. We should use standard forms when for the language of morphological diagnosis, which would be clear not only for pathologists, not only to morphologists, but also to other specialists. The group involved in studying diseases of the GI tract, like digestive zone, the tumor and non-tumor disorders. That's a photo of the place where our lab is located. So those who live in St. Petersburg, that's a place of confluence of Fontanka River and the Griboyedov Canal, with a so-called Novokalinkin Bridge, and with a cluster of clinics here. Here, this third floor of this building, there is a lab where I present here, and I would like to thank you for your attention. Thank you. Thanks a lot, Sergey. And many of the samples from this laboratory of yours, they come from our facility. You could refer patients to us. Are there any questions to Sergey? Yes, please. Please pass the microphone to our colleague. Sergey, could you tell me, please, biocytology diagnostic method, is it of any value? Well, theoretically, yes, maybe. But in a morphological practice, we should understand that the most definitive issue is amount of the material, no matter which method you use to take it. So the more of the cytological or tissue material you provide to a morphologist, to a cytologist, then the better options, the better chances for diagnosis. So theoretically, maybe yes, but practically, I haven't heard about the cases cytologists would use this method for diagnosis because the medium for obtaining cell structure is not the right one that we use. So I don't think it's highly likely that's going to be used for that, for diagnostic purposes.